and then start your speech. You can go live now.
Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management options. For this webinar today, we have with us our guest speaker, and I would like to take a moment to introduce him. Today, we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of almost 38 years in this field of pediatrics. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune. Also, he was an ex-president of the Indian Academic Pediatrics in 2016. In addition to that, Dr. Pramod Jog was an ex-standing committee member of International Pediatric Association and ex-steering committee member of Gavi. Dr. Pramod Jog practices at Jog Children's Clinic in Pune, and he completed his MD and MBBS from BJ Medical College, Pune. So with this introductory note, I would request sir to take over.
Yes, Mr. Manor, just 1 minute. Okay, is the screen visible and my voice audible?
Yeah, sir, your screen, sir, voice is audible and screen is visible, sir.
Thank you. Thank you.
Yeah.
Okay. So, my dear friends, it is a matter of great pleasure to interact with you on this particular topic of what is new in flu. Now, actually, flu is a very naughty virus, and that is because it changes its structure every year, and all of our colleagues who are in practice and who give vaccines to the children, they know that every year the vaccine which comes into the market has some change in the strain which is present in the vaccine. Okay, and it is very important to know the basis of this particular change in the strain. You will all agree with me that during this year 2023 we had H3N2 in the last 2 months, and you will be rather able to find in the literature that H3N2 is supposed to be much more serious as compared to H1N1 even world over, and that's why it's quite interesting to know many facts about influenza. And you can see that the nomenclature of the influenza virus can be applied even to my name. So the type of the flu virus, that is Z, that is Zog, of course, and the geographic location, that is Pune, then the strain number and the year of isolation, and then the real name of the virus. So remember that every one of you can try putting your name in the fashion of influenza, and you will also remember that the strain of influenza in IAP is the changing strain of the president. So I was the 2016 strain of IAP presidents. Anyway, with that, I will just give you some important points about this particular disease. And I will start with a case who was a 3-year-old boy who came to me for fever, cough, and cold, and progressive breathlessness for almost 3 days. The child was obviously tachypneic, and saturation at room air was 85%, and the blood gases revealed acidosis. When we saw the X-ray, it was showing ARDS, okay, and he was admitted to the PICU. He was ventilated, and he received oseltamivir and the supportive treatment in the PICU. And the throat swab was positive for H3N2. He was ventilated for 3 days, and then he was fine. Okay. Now he'll ask me as to what is so different in this case. There is nothing very different, but the point is whether this particular child would have been put on early oseltamivir when he was previously healthy and presented with cough, cold, and fever. So he was progressing over 3 days, but at that time, one never thought of putting this child on oseltamivir. So whether this progression would have been prevented, and whether every patient of cough, cold, and fever be given oseltamivir upfront, particularly in the flu season. So that is the main question. And there are quite a few points which lead to what I call as confusion. It is the confusion about flu. And the first is whether this is bacterial or viral. If it is viral, which is the virus? Is it rhinovirus? Is it adenovirus? Or is it influenza? Okay. And should I start oseltamivir upfront? Okay. And should I give every patient antiviral to play safe? So remember that some of these points will always create a confusion in the mind of the treating physician. And the first question, of course, is whether this is bacterial or viral. Remember, my dear friends, viral infections are generalized. Usually, viruses will attack more than one system. It will produce cold and cough. It will also produce discharge from the eye. It will produce rash. It will also produce diarrhea and so on and so forth. While bacterial infections, as all of us know, they are localized. So if a child has follicular tonsillitis, he won't have pneumonia. Okay. If a child has bacillary dysentery, that is a bacterial infection with Shigella, he won't have acute follicular tonsillitis. So it is important that you are able to differentiate the viral infection from bacterial. Another point, when fever comes down in a child who has viral infection, the child starts playing, eating, and smiling. And in the interfebrile period, he is absolutely fine. But a child with bacterial infection, say a child with pneumonia, this particular child, even after the fever comes down with paracetamol, continues to be sick. He doesn't eat, he doesn't play, and mother says, he is not the usual self. हमेशा जैसा इसका बर्ताव नहीं है. He is appearing a bit different. So these are some important differences in these two infections, and that is why we should know that there are many viral infections, but we should know as to how to basically differentiate bacterial from viral. And with this background, we will try to understand the challenges related to the flu, the complications, and the evidences for the use of oseltamivir and the guidelines for its recommendation. And recently I came across one small little girl who was about 7-year-old, and she came to my clinic with minor complaints of cough, cold, and fever, and obviously she had viral infection. And I was telling the parents that don't worry, this is viral. So the girl also started consoling the doll in her hand and started telling her, don't worry, it is viral. Okay, so even small little children these days, they know that viral infections are mild and nothing is to worry about. But my dear friends, this might become the story of the past, because so many viral infections have come in this particular post-COVID period. And we have witnessed right from the months of June and July last year, when first I witnessed that hand, foot, mouth disease. Then came the period when we had respiratory syncytial virus. Then we had in Maharashtra measles, so many cases. Then we had H1N1, and then we had adenovirus, and now we have H3N2. Now, even older children are getting affected with these different viruses. And these waves of different viruses, as if one is waiting for the other to be over. Okay. All these things, they happened probably because during the period of COVID, these children did not have any immunity against these viruses. Most of the children were at home. They did not go to the school, and there was no question of exposing them to these different viruses. And that is why these children did not have any immunity against these viruses. Okay. And what is the picture in the OPD these days? We are encountering so many children with recurrent respiratory infections. We have children who have otitis media. We have children who come to us with snoring and mouth breathing, and these are the children with adenoidal hypertrophy. We have surge in influenza, and I told you it has been unseasonal. Usually, influenza is a disease of monsoon or the post-monsoon period, but now we are getting influenza in the months of March and April. And then we had that adenovirus. This adenovirus has really become a bad adenovirus. It has become really bad. That is because it is showing varied presentations. Not that we do not know that adenovirus can come with varied presentations, because my teacher, I remember, he used to ask me, which is the respiratory virus which has more of non-respiratory presentations? And the answer you expected was adenovirus. Okay, that is because it not only produces pharyngoconjunctival fever, but it also produces diarrhea and mesenteric lymphadenitis and hemorrhagic cystitis and so on and so forth. So one has to be aware of this adenovirus. And this time, this virus is also producing a bit of a prolonged illness. Usually by the end of 5 days, the fever should disappear. But then for 7 days, 8 days, the fever doesn't disappear. And the pediatrician is worried as to why the fever is not going down. And then already probably if he has started the child on amoxicillin, then he is rather wondering whether I should switch over or shift over to something stronger. And you must remember that adenovirus is producing a bit of a prolonged illness. Okay. And then there are some diagnostic problems like CBC and CRP. They are high in a child with adenovirus. Of course, in influenza and COVID also, CRP is on the higher side. Then we are worried whether I should send nasopharyngeal swab for the diagnosis. And we always have the dilemma as to whether we should put this child on antibiotics, whether I should put this child on antivirals or I should do nothing. So many children in the last few months have received metered dose inhalers and intranasal steroids. So if you see the scenario of the respiratory infections and the points around these infections, there are many. And it's our duty to understand a few of these points which will help us in the day-to-day practice. Okay. So another child, Viru, I have named him Viru because this is viral. He came for fever for 3 days. And the mother, as usual, was an anxious mother. She said, okay, Dr. Jog, I understand that this is viral because this child has cold and cough. However, this child was on metered dose inhaler since 4 months with well-controlled behavior. And I just gave symptomatic treatment. Again came back after 3 days. He was afebrile for a day and fever came up again. He was active in between. So I told, remember, this is viral. And these are recurrent viral upper respiratory infections, which have become more frequent. And they are occurring at a shorter interval. Okay. And obviously, we are not going to give antibiotics for these children. The question is how to counsel these parents. So what I tell them is that after COVID, the behavior of some of these viruses has changed. The disease has started showing itself for a longer period. It may take 3 weeks for your child to settle. For example, adenovirus. And of course, if he settles in 2 weeks, the entire credit goes to Dr. Jog. Okay. So remember that you have to tell the parents that it's going to take long. The cough is also going to take long. So don't worry, relax. You have a lot of authority and the parents would believe in you. Of course, there are some patients from the IT sector. IT does not mean the information technology, but they are the inquisitive and the troublesome parents. They will ask you questions every day. Even if the fever rises by 0.1 degree, they will call you. And, it's important that you counsel them properly. Okay. Now, that is the reason why you should be aware as to which organisms affect which part of the respiratory system. So who loves whom? So whenever a child has involvement of the nose, say by rhinovirus, it's viral 100%. Okay. Tonsillopharyngitis in 70% cases is viral. Which viruses produce pharyngotonsillitis? Rhinovirus, influenza, parainfluenza, RSV, adenovirus, enteroviruses, so on and so forth. While in 30% cases, pharyngotonsillitis is bacterial, where we have group A beta hemolytic streptococcus. Otitis media and sinusitis in majority of the cases are bacterial, and in some percentage, they are viral in nature. Remember, pneumococcus and Hib, if they are isolated from the throat, then they are colonizers and not the pathogens. Okay. So you should know whether you can identify your enemies. This is an educated guess. So if the onset is with cold and sneezing, think of rhinovirus. As I told you, it's common cold, upper airway involvement. There is mild or no fever. There is no exhaustion and children play very well. It could be also because of influenza or parainfluenza or RSV. Along with high fever, if the child has prominent headache, muscle pain, extreme weakness, remember this is influenza. Okay. And whenever a child comes with these symptoms, it is important that you put this child on oseltamivir empirically, provided the child is appearing serious, provided the child has epidemiological background of flu in the surroundings. Okay. And then the adenovirus, which I told you, produces pharyngoconjunctival fever. In addition, this time we have seen producing exudative tonsillitis, also pneumonia, in some cases effusion, and along with those non-respiratory manifestations. In a child who is under the age of 1 year, you must always remember that bronchiolitis because of respiratory syncytial virus is common. If it's fever with dry cough, we have witnessed COVID-19, wherein we had also the loss of the sense of taste and smell in an adolescent. Okay. And if it comes to bacteria, fever, follicular tonsillitis with a tender cervical node, this is streptococcus. And if there is fever, grunting, the mother says, "Ye bacha aisa karta hai raat mein, if that is the sound that the child is producing, where the child needs more of oxygen, and the child is obviously tachypnic, then it's pneumococcus. And if the child is rapidly progressing and he is toxic, from pneumonia is progressing to effusion and then to empyema, think of staph. And beyond 5 years, if it's predominantly cough, less of signs, then in school going children, we think of mycoplasma. Now, the purpose of knowing all these enemies is that at different places, say in the interiors of UP, we do not have diagnostic facilities. Where is this child going to go to do that nasopharyngeal swab, which, people from the major cities and the metros, they always keep saying, about the nasopharyngeal swab and the panels and so many other things. Okay. So remember, we as clinicians must be able to guess as to what is this organism. Of course, it's not possible. Even Rajnikant cannot differentiate what is the type of virus, whether it is influenza or parainfluenza. So it's only an educated guess, which we must remember. Okay. So I had this child, a 4-year-old child with cough and fever of high grade for 5 days. Obviously, one gentleman had started amoxicillin on the 3rd day, but the child was not settling. On admission, he was tachypnic and needed oxygen support. And you can see that the X-ray is showing pneumonia on the right side. And in the hospital, we have a protocol, and fortunately, we have the facility for the nasopharyngeal swab. So the hemoglobin, TLC, and differential count and all, you can see that the total count was low and the platelets were also low. And the nasopharyngeal aspirate was positive for H3N2. Now, see the fever going on for 5 days. Anybody with this kind of an X-ray would, put this child on IV fluids and ceftriaxone, so on and so forth. But this child, remember, had H3N2. Another child of H3N2, again, fever for 5 days, fever not settling. The counts were normal, and the nasopharyngeal swab showed H3N2, and you can see the X-ray. Okay, but fever going on for 5 days. And another child where the counts were normal, but the CRP was on the higher side. And again, the child showed H3N2. You can see that the X-ray involvement on the right side is obvious. Okay. And then this 4-year-old child with cough and cold for 5 days with high WBC count and high CRP. Now, anybody would think of bacterial pneumonias. And he had continuous high fever for 5 days. And the nasopharyngeal aspirate showed adenovirus positive. What we do is that initially for 2 or 3 days, if the child is fine and not much, serious, then of course we give the symptomatic treatment. After day 3, we do investigate in the form of hemogram and urine and chest X-ray and so on. And depending on the severity, by the end of 5 days, we take a call. At this time, in case if the child is still not settling and he is on amoxicillin, then we usually send the nasopharyngeal swab for these different viruses. We have some panels wherein we only can have flu along with RSV, along with COVID, like, expert flu. That's the name of the panel. So looking at the pocket of the patient and the availability of the test, we go ahead with these tests on day 5. So here it was adenovirus positive. Now there was another girl, interesting case, who was 5-year-old with high fever for 5 days and cough and cold. She was sick. She had mild wheeze, but there were no crepitations. And we were thinking as to whether we should put this child on antibiotics. Of course, we waited for some time. Remember, whenever a child has sneeze and wheeze, we usually think it as viral and we do not put them on antibiotics. Okay. If there is change in voice, we take it as viral. We don't put them on antibiotics. Now, with all said and done, and with this child admitted and put on intravenous antibiotics, and the total count on the lower side, and CRP a bit on the higher side, again a confusing situation. And we had put this child on oseltamivir till we did not have the report, and the nasopharyngeal swab showed rhinovirus. Okay. Now the point is that rhinovirus is an innocent bystander. He is, of course, not creating any problem in the clinical picture. So many a times we get influenza with rhinovirus, adeno with rhinovirus, so on and so forth. But just as sometimes we have neighbors who enjoy the fights between the husband and the wife. This rhinovirus who stays in the neighboring society, he only remains there. He doesn't create any problem. So some of these viruses, they are always seen in those reports. So you need not worry about them and treat the basic condition depending on the clinical progress. Many of my friends, they ask me, in case if the patient cannot afford all these tests like nasopharyngeal swab and all, what do we do? Remember, you have to treat the child and not the investigations. That is the principle that our seniors have taught us. And that is why, now let us see this child who is a 7-year daughter of those IT sector parents and came for high fever for 3 days and throat irritation. And the child had examinations 2 days later. The throat was only showing mild congestion and we put her on paracetamol. Of course, the flu and the adenovirus being around, the parents also, were asking continuous questions. What is this? Then I told them this is viral. Then they say, how are you sure that this is viral? Then I said, these are the mild symptoms. And in the initial 3 days, it is like that. Then they say, we would like to confirm it by doing nasopharyngeal swab. We would like to put this child on antibiotics, so on and so forth. So when you manage such children, always look at the severity. Okay. Always remember, if the child has mild presentation, mild fever, mild cough, mild congestion in the throat, then it's almost always viral. Just because it is taking a bit longer, we have to be aware that some of these viruses have started behaving differently, and not that every child needs a throat swab, not that every child needs empiric oseltamivir. But if a child, a 3-year-old boy, comes to you for cough for a week and high fever for 3 days and crepitations, then you have to be always careful. Why? Because here it is possible that the child, because he has symptoms going on for a long time, has been put on amoxicillin by someone and he is admitted for persistent fever, but he has crepitations, lower respiratory tract involvement, and you put him on IV antibiotics, you admit him. See, the CRP is normal and the swab shows influenza A, and here you are fully justified in putting this child on oseltamivir. You can either stop the antibiotics or maintain them at the level of amoxicillin, because 25% cases of influenza have associated pneumonia, like Streptococcus pneumoniae or Staph aureus. So all these are known in cases of influenza, and that's why co-infections are known in influenza. So depending on the individual child, you can take a decision. Okay. However, if the younger child comes to you in the morning with high fever for a day, then you are fully justified in putting this younger child on oseltamivir, because the transmissibility of influenza to the other chaps in the family, the children, and also to the others in the family, like the father who is a diabetic, a mother who is pregnant, and a grandfather who is asthmatic, and the grandmother who is on steroids for some kidney disease. So it is the children who spread it to the adults in case of influenza. While COVID, we have seen that it is the one which spreads from the adults to the children. So it is very important that you take care of this child so that it doesn't spread the virus to others in the family. Okay. And that's why it is important that we know the KYC. KYC is the bank terminology, which stands for Know Your Customer. Okay. And we are always asked about the Aadhaar card and the PAN card and so on and so forth. So as far as the influenza is concerned, I told you that it's an RNA virus, and the RNA virus is the one which shows mutations. Even COVID, which has been an RNA virus, it has shown different mutations in the last 3 years. And it is a well-known fact that the RNA virus are the ones which show frequent changes. And as regards flu, there have been 4 major global pandemics. First one was in 1918-19 when it was Spanish flu, and there were 500 million cases and 50 million people died in that pandemic. Then it was 1957 when it was H2N2. Then it was 1968 when it was H3N2. And then 2009, which was again H1N1. During our tenure, we have witnessed the 2009 pandemic and the recent 2020-2021 COVID-19 pandemic. So flu appears, like innocuous, but it is not so. Okay. And all those H3N2 viruses have been linked to the high fever and the cough cases. And ICMR has conducted some studies, which I will show you in a minute, that in the first 3 months of this year, H3N2 has been the major, virus producing those cases of influenza. Remember that flu was once considered as seasonal. We still maintain that statement that during monsoon and post-monsoon, we do get more of cases in most of the parts of our country. But now it has become perennial. All throughout the year, we are getting the cases of flu, and there has been a surge in the cases of high-grade recurring fevers in children. Okay. So whenever a child is brought with runny nose, fever and cough, and headache, body ache, muscle pain, and weakness, always think of influenza. Okay. And as I was just trying to tell you, ICMR studies have proved that it's H3N2 which has created the problem in the first 3 months of this year. Healthcare related challenges have increased, not because we are unable to diagnose the type of virus, but then the precautionary measures that we have to take and we have to be so careful about, to which we were never used to. Okay. And then remember that flu in India and the related deaths, basically there is an increasing trend, alarmingly increasing trend related to deaths also. And this flu virus, as you all know, has a high transmissibility. There is a term which is used called as R0, also known as R0, meaning thereby a child with influenza can spread the virus to a few others. There could be 2 or 3 people. There could be measles, which can spread it to other children. There could be COVID, which can be spread to other children and other people. So remember that this infectivity for influenza is quite high, and it's a contagious airborne disease which occurs in seasonal epidemics and manifests as acute febrile illness and can cause mild to serious illness, and the serious cases need to be hospitalized. So we should not take this particular infection lightly. And that influenza A is the one which is the cause of those frequent epidemics. I told you that every year we have a different strain. It's quite interesting. See, if my name Pramod goes and changes into Vinod, that's a minor change. Okay, this is called as a drift, which occurs every year. But if suddenly my name from Pramod changes to Bhaskar, these 2 names have no connection with each other at all, and this is called as a shift. So influenza A in the atmosphere survives in the birds and the pigs and the human beings. Okay, so when influenza virus from the birds and the influenza virus from the human beings comes together in the body of a pig, okay, then the pig acts as a mixing vessel, something like the bhel that we eat outside. Okay, so we have the mixture of so many things like the dal, the sev, the gathia, and so many things together. So the pig will produce a new, totally new, major antigenic variant, and that is the cause of the pandemic. Okay. Now, influenza B infects only human beings. It doesn't infect the animals. And that is why influenza B does not produce pandemic, because there is no question of mixing of those different strains of influenza. While influenza C is a mild chap and only produces a mild respiratory illness. But the current strains which are circulating are H1N1 and H3N2, and people with flu can spread it to others up to about 6 feet away. The flu viruses are mainly spread by droplets, just as COVID. And when people cough or sneeze or talk, these droplets land in the mouth or the nose of the people who are nearby. and these are the ones which are inhaled into the lungs. And people should stay away from the affected person and stay home if they are sick. It's also important to wash the hands with soap and water. Remember, our people do not many times are aware as to the way one should cough. Okay. Now, for example, if I cough, I should actually cough in the elbow. So coughing an elbow is called as a Dracula cough. Okay. You should not cough in the palm, because the palms are usually the ones which come in contact with things around and could spread the virus. Most of the healthy adults, they start infecting others one day before the symptoms appear, and they keep infecting others for almost 5 to 7 days after they become sick. And in case of children, the spread of the virus is longer than 7 days, continues for 10 to 14 days. And this is what I was trying to tell you, that it's difficult to differentiate different viruses which are affecting the respiratory system. That's fine. But even in between flu and COVID, there are some differences which we should be aware of. So fever and pain in the muscles and cough and weakness and sore throat are common to influenza as well as COVID. Remember, the word ILI means influenza-like illness. Most of us know that. However, influenza is the father of all those influenza-like illnesses. It is the one where, the child has headache, high fever with chills, and muscle pains. And parents, many times, they simply lift the child who is so weak that he himself cannot come to the clinic climbing the stairs or walking. Okay. And S3N2, as I told you, is also much more rather serious as compared to H1N1. And some children who have severe acute respiratory infection, they can become breathless. Okay. Of course, flu and COVID, these are the two respiratory viruses which commonly affect the lower respiratory tract. Most of the others usually remain in the upper respiratory tract. Of course, as I told you, the different viruses, in addition to influenza, like adenovirus, RSV, we have seen that bronchiolitis in small little children, that's nothing but low respiratory involvement, and COVID also. And in case of COVID, we know that there is loss of the smell and the loss of the taste. Of course, diarrhea is something which can occur in COVID-19, and headache is more common in influenza. There are some differences, but to be frank enough, it's really, really difficult to guess what it is. And that's why sometimes we are puzzled. So the categorization of these influenza-like illnesses cases is important. Why it is important? The only reason is that we are not going to chase the name of the virus, but we are going to chase the clinical presentation of this particular disease. So if a child has mild presenting features like cold and cough and fever, we put it as a type A. If there is increase in the respiratory rate, it becomes type B. And if it is a distress, it becomes type C. Same as COVID. However, our duty is to inform the parents that if this child starts, having fast breathing or cyanosis, or if he is not drinking enough of water or fluids, if he is not waking up, or he is not interacting, he is so irritable that doesn't want to be held, or when the symptoms are improving and again appearing with fever and worsening of the cough, indicative of secondary bacterial infection or pneumonia, then parents must report to you. Why this is important? Because many a times parents come to you for one time. I have seen once the child is little better, parents have a tendency not to visit the doctor again. Who loves to visit the doctor and again? There are very few. So I make it a point and tell them that, see, if you come for a follow-up, I will not charge you. Okay, please tell them, so that, at least they are not worried about the fees that they need to pay, because our community in majority of the parts of the country is poor. Okay. And these illnesses unfortunately affect the poor to a great extent, where there is overcrowding and so on and so forth. So it is for your learning. So I tell them that, see, I want to see the progress of the child. I want to see the health of the child. So if you disappear after taking, some of these symptomatic medicines, then I will not know what is going on after 3 days. So I try to convince them that they should come back on day 3 and day 5. And then I am, convinced that the child doesn't have fever and now he is improving. But my dear friends, complications of flu are also to be remembered. They are all, starting from the alphabet A. I have, made this particular presentation, particularly this slide, for you to understand. ARI, that is acute respiratory infection. As I told you, it can produce pneumonia, or ARDS. Acute otitis media, absenteeism from the school, and in case of adults, it is the absenteeism from the work, which affects the amdani, that is the income, and the antibiotic abuse. I told you it's difficult to differentiate even viral from bacterial pneumonia, and that is the reason why many children, start getting antibiotics. So the respiratory complications like otitis media are seen in almost 10 to 50% of children, and the typical time of onset of otitis media is 1 to 4 days after the onset of influenza symptoms. Okay. Pneumonia. Primary viral pneumonia is common in children who are having underlying risk under the age of 2 years. And usually, as I told you, it's associated with Streptococcus pneumoniae or Staphylococcus aureus co-infection. Now, exacerbation of chronic pulmonary conditions like asthma, particularly in children who are above 2 years, hospitalized patients, that is also known, and respiratory failure, which occurs in about 5%, and acute laryngotracheobronchitis producing croup. Okay, this is a child I would just like to share with you, came again last month, a 6-year-old child with cough, cold, and fever and respiratory distress. And he had involvement of the heart, the liver, and the lungs. And he was rapidly progressing, and he was put on HFOV, high frequency ventilation. And this child, you can see him here in this particular picture. And on the right side, there is a report of this particular chap, which shows influenza B, okay, that was detected. This child also had concurrent Streptococcus pneumoniae and Haemophilus influenzae, okay. So it was a co-infection. And remember, whenever there is co-infection, these children are always much more sicker than simple influenza, okay. These children can also have toxic shock syndrome. They can have cardiac involvement in the form of myocarditis and pericarditis. And another child, a 1-year-old child, came again 15 days back with fever, cough, cold, and status epilepticus. He almost came convulsing in the OPD, and the nasopharyngeal spirit showed H3N2. The counts were normal, and the MRI showed non-specific encephalitis changes, and it was influenza encephalitis. So you should be aware that the child with influenza can have simple febrile convulsion. He can have influenza-associated encephalopathy due to cytokine dysregulation, which we have been discussing during COVID so often. They can have acute necrotizing encephalitis, Guillain-Barré syndrome, and aseptic meningitis. And myositis, that is the one which leads to muscle pain, particularly in 6 to 9-year-old boys, particularly with influenza B, with involvement of both the gastrocnemius and the soleus, with severe bilateral calf muscle pain and inability to walk. And involvement of the liver, particularly in children who receive aspirin for influenza B, and this leads to Rye syndrome, which is a condition akin to liver cell failure. Okay, so with all these complications and the problems, we must understand what is the management of influenza. And for every child, we must offer him bed rest and increase in the fluid intake, suppressants for cough, antipyretic analgesics like paracetamol, and apart from aspirin, avoiding aspirin, you can give other medications, particularly if there is fever and myalgia. Okay, most of the patients with influenza will recover in 3 days, but the malaise may persist for weeks. And if the child is sick and serious, then he may require admission, IV fluids, and other supportive care. But the mainstay of therapy is oseltamivir, which is a neuraminidase inhibitor. Remember, this influenza virus has 2 layers outside, and these lipid layers have some proteins which are spike proteins, and they are H and N, hemagglutinin and neuraminidase. Hemagglutinin is the one which attaches itself to the respiratory epithelial cells. Remember, viruses are perfect parasites. They want some other living cell to survive. So when they have entered the human respiratory system, they will try to attack the respiratory epithelium, and the hemagglutinin is the one which tries to attach itself to the respiratory epithelium. And neuraminidase is the one which is responsible for replication of the virus. See, the virus is nothing but a virion, the copies of RNA. So it replicates, and from one virus, from one respiratory epithelial cell, the virus wants to send it to the other, and then to the other, and replicate. But this neuraminidase enzyme is the one which is critical in releasing the virions from the infected host cells. And oseltamivir blocks this release. And this is what you must remember. If you use it early, obviously this release will be halted early and the spread of the disease will be less. So by 1 or 2 days, the severity of the illness comes down when you use oseltamivir. You can have a look at this picture where you can see the virion on the upper portion of this slide, wherein there is release of new virions and continued viral replication. But here in the lower part, I have shown you a red cross where the virion is not able to now pass on other virions to other cells, and then there is a halted viral replication because of neuraminidase inhibitors. Okay, so remember that oseltamivir, which is a prodrug, it is converted to the active form oseltamivir carboxylate in the liver. It inhibits the influenza virus replication and pathogenesis, and it prevents the further spread of infection. And it is useful in all the strains of influenza A as well as influenza B. Okay, it was the first oral neuraminidase inhibitor, and it had been approved in more than 100 countries. And this particular slide will give you the dosage and recommendations. Remember, the dose for adults is 75 milligram capsule twice daily. Most of us know that, and the capsule is easily available. But if there is chemoprophylaxis for a person who is at a higher risk, as I told you, those who are having diabetes or chronic pulmonary conditions, and those who have some steroid therapy going on and some congenital immunodeficiency, so on and so forth, there you have to give 75 milligram capsule once daily. When it comes to children under the age of 15 kg, they require 60 milligrams of oseltamivir per day. Now, there has been a 30 milligram capsule of oseltamivir which has recently come into the market. And if you want to give it 30 milligram capsule in the morning, 30 milligram in the evening, that is 60 milligrams per day. That means we have divided 60 into 2. And we have saved some medicine, because if you see the syrup, if at all you start giving it for all, many times it is wasted because the dosages in children are less. For a child who is 23 to 40 kg, the dose is 120 milligrams per day. That is 4 capsules of 30 milligrams. So you can give 2 in the morning, 2 in the evening. And obviously you can plan the therapy depending on the strength of the medication available. Of course, for small children, younger children about less than 1 year of age, then you have to give 3 milligrams per kg in the twice daily dosage format. And these are the children wherein you can use the syrup. Now, oseltamivir 30 milligram capsule is of great help for children who are 15 kg or less, where the treatment dosage for 5 days in the dose of 30 milligrams twice daily, and for prophylaxis for 10 days, it is 30 milligrams once daily. Remember, the prophylactic dose is only once daily and it is for 10 days. So there is a dosage convenience, there is no wastage, and it's also quite economical. And there are quite a few benefits of the empiric and the early use of oseltamivir, which has been proved by clinical trials, wherein the low respiratory tract complications and the antibiotic use in some of these subjects was reduced. Also, the occurrence and the severity of pneumonia due to H1N1 was reduced. And even in case of adults with community-acquired pneumonia, where H1N1 was proved, the onset of pneumonia and the hospitalization was reduced. WHO has recommended empiric therapy strongly. And WHO says that treatment should be started as soon as possible. Laboratory confirmation of influenza virus is not necessary for initiating the therapy. And negative lab tests for H1N1 does not exclude the diagnosis, because these tests are not positive in all patients of influenza. Okay, so your clinical judgment is important. And if the high risk individuals have been exposed to the patients of influenza, you have to think of prophylactic therapy. And even the Ministry of Health and Family Welfare have endorsed the early empiric use of oseltamivir. Now, in a given child, how do we proceed? This is very important. See, when a child comes to you with fever, cold, and cough, as I told you, classify. If he's a mild case, leave him alone for 2 to 3 days with antipyretics, antihistaminics, and maybe nasal drops and plenty of fluids. At the end of 3 days, reassess the child. If the child is worsening, then obviously you have to put this child on oseltamivir. At the same time, if you find that only fever is persistent, okay, then you are always justified in sending the hemogram and the CRP and the X-ray test. And of course, in pediatric practice, we do the urine test also and get an X-ray test and find out what's going on. By the end of 5 days, if the child is still unwell, okay, then you are fully justified in repeating some of these things like the count and the CRP. And in case if it's showing some bacterial infection evidence, you can put this child on amoxicillin, provided it's a respiratory problem. At the same time, if the child is worsening and the respiratory rate is increasing and he is going into distress, of course, you will have to admit this child and send a nasopharyngeal swab, provided you have the facility. Oseltamivir continues. Okay. By the end of 7 days, if you get a report and if you get the clinical condition of this child, you will be able to find out as to what is the situation. If you are lucky enough, you get influenza or adenovirus. Okay. But if you are not able to get anything, then obviously this admitted child will be on IV fluids, injection, ceftriaxone, and so on and so forth. So my dear friends, it's all the clinical judgment, and the nasopharyngeal swab is only to assist you to continue your treatment. Now, quite a few of my colleagues, they ask me as to what is the validity of these nasopharyngeal swabs and others. I told you that there is something called as a diagnostic stewardship. Okay, we always speak of antibiotic stewardship. Use antibiotics rationally, use them when they are only necessary, don't use them if they are not necessary. I told you that in sneeze and wheeze, and also in case of change of voice and acute watery diarrhea, don't use antibiotics. That's fine. Okay, but then even for diagnosis, we have to be careful. We cannot keep sending the throat swab of each and every child coming for respiratory symptoms right on day one. We have to weigh the situation. If the situation is mild, we please tell the parent that, see, this is a self-limiting condition. All the respiratory viruses, usually within a period of 5 days, they settle and the child will be fine. Okay, so we don't want to increase the burden on our laboratories by unnecessarily sending the nasopharyngeal swabs. But if the child is worsening, if the child's respiratory rate is increasing, if he is going to distress, if fever is not settling, if he is admitted, please always go ahead and make the maximum use of the investigations which are available with us. Okay, and that's why I said, what is the meaning of antibiotic stewardship in this context? If the child's PCR, say for example for H1N1 or H3N2 is positive, then at least you can stop the antibiotic which you have started, or you do not escalate the antibiotic. So on day 5, already a child who is on antibiotics, okay, and if you get a report which says H3N2, then at least do not go from this amoxicillin to ceftriaxone and then to further vancomycin and all. Okay, our colleagues, many times they get jittery. Oh, the fever is not coming down, what to do? So please remember that when you get a child where the PCR is positive for a virus, then at least do not escalate. Continue with oseltamivir. And I told you, oseltamivir given early will always give you excellent results. Even when you use oseltamivir after 5 or 6 days of illness, when the child comes to you with fever and respiratory involvement, then you can use it, because it has been found that it reduces the complications, hospitalization, and the mortality. And the replication of the virus continues. I told you, children continue to spread it for a long time. And that is why oseltamivir, even given later in the course of influenza, is of great help. So my dear friends, remember that the disease influenza is showing a different unusual pattern. Most of us are witnessing either H3N2 or influenza B or even H1N1, and you have to treat them properly early and also go for a proper diagnosis whenever indicated. Okay, you have to also remember to prevent the flu complications. Okay, and the empiric use of oseltamivir will reduce these complications and hospitalization and antibiotic abuse. And many of those reputed societies, including WHO and Ministry of Health and Family Welfare, they have recommended empiric use of oseltamivir. A few words about the flu vaccine. Remember the short form NESCAFE: need, efficacy, safety, cost effectiveness, affordability, feasibility, and epidemiology. Whenever a vaccine is being considered, please see, is this vaccine needed? Yes, flu vaccine is needed for all those reasons that we saw, the complications and so on and so forth. Is it efficacious? See, all those 4 strains that I told you, H1N1, H3N2, and the two lineages of type B, that is the Victoria and Yamagata. All are always present in the vaccine. However, these strains, if they are present in the atmosphere and also the same strains exist in the vaccine, then this match is very good. In match, in our term, we use the word kundali. So if the kundali of the atmospheric viruses matches with the kundali of the vaccine viruses, then the efficacy is going to be great. Okay, that is why WHO wants that every year, different sectors, they inform WHO about the different viruses which are circulating. For example, during this monsoon now, 2023, from June, July, August, September, whatever viruses are in circulation will be detected by the institutes of virology, and they will be informed to the WHO in the month of October. So for the next year, WHO knows which are the potential strains of the virus for 2024. Same is true about the vaccine, which is, available after the months of October, so-called as the Northern Hemisphere vaccine, and so on and so forth. The point is that the nearest possible strains are the ones which WHO is trying to, manufacture. Okay, the vaccine is quite safe, and the cost is also not so much, so it's cost effective. It's also affordable, and the vaccine is given at the end of 6 months in the baby in the first year of life, and second dose is given at the end of 7 months in the first year of life. This is an inactivated vaccine. When the child comes to you for the first time after 9 years, then only single dose is required. And remember, I already told you about the epidemiology. Okay, and it is important that you give it to those who are at high risk, those who are above 65. If at all you get the mother who is pregnant, please advocate vaccination, because pregnant mothers are, at a risk of influenza. And in the first 6 months of the life, there is no protection to this child. See, we give influenza vaccine after 6 months. So the maternal antibodies related to influenza, that means anti-influenza antibodies, will pass on to the baby and protect the baby for the 6 months also. And also influenza will be avoided in the pregnant mother. What I do is, at my clinic, it's happy birthday to flu. What does it mean? We always say happy birthday to you, but all the staff members, the ward boys, the ayas, and the staff nurses, and so on and so forth, including the resident doctors, every birthday, they will receive their flu shot free of cost in my hospital. That is because it's our responsibility to protect our people. Okay, we have so many children coming to us, and I told you that children are the ones who spread it to others. And also remember that they must wear mask, because so many different viruses. I told you right in the beginning that the waves after waves of different viruses are coming. Let us protect ourselves and let us not be casual. Okay, so every birthday, please make it a point to give flu vaccine to your nearest and the dearest ones, and also the staff members of the hospital, and say happy birthday to flu, so that you remember this. Okay, so my dear friends, this virus is a fast and a furious virus. Okay, I remember to have seen this movie when I was in my college days. And then this virus also has an abrupt onset, high transmissibility, rapid progression, fast development of ARDS, and a fast vertical discharge, that is death. Okay, and oseltamivir is the one which acts very quickly. Of course, in addition, you must take the sanitization and the masking and the social distancing precautions, along with cough etiquettes like coughing in the elbow, and the 5 sutras related to the hand, in the form of hand washing, hand shaking to be avoided, handkerchief to be used, keeping others at a hand's distance, and avoiding the hand touching to parts of the face like the nose and the mouth and the eye. And that's why always remember to say namaste. Namaskar is our Indian tradition. Even the Westerners have now taken up this particular habit, because they know the importance of avoiding a shake hand. Okay, and that's why all of you must remember that you will be able to control the flu, because flu ends with you. Remember, this is important, and that is why I always appeal all my colleagues to take care of themselves by these preventive measures, vaccination, and whenever there is a child with influenza, avoiding the morbidity and mortality by giving early oseltamivir. Okay, with that, I stop sharing my slides, and I am thankful to all the listeners for listening to me patiently. And Mr. Manohar, if there are any questions from the audience, please feel free to ask them.
No,
And
sir,
in
there are
case if
no,
there
sir,
are
no
no
questions
questions,
are there, sir, today.
very good. So
we
it
can
means
conclude the session.
yes.
So, sir, thank you so much for making this topic very simple manner, and in a practical way you took the session today. I hope whatever the, things we have shared today in this webinar with your practical experience will definitely help the attendees in their day-to-day practice. And together we can beat the flu with this. And that is the reason why. Thank you, sir. And thank you all the delegates who attended this webinar till the end. Okay, that is the what's new in flu. That is the current challenges and management option. Thank you so much.
Thank you.